A number of children and adolescents in the U.S. suffer from mental health disorders. They're primarily treated in ambulatory and community mental health centers, and nurses focus on assessment, identification, referral, education, and support of the child and family, also on working collaboratively with the interdisciplinary team. Risk factors have been associated with increased risk for mental health disorders in children. These include trauma or neglect, difficult temperament, attachment problems, experience of major losses, negative sibling relationships, medical problems and illnesses, exposure to high-risk activities such as drug abuse, poverty and homelessness, and even parental substance abuse. Common treatment modalities include individual therapy, which involves the child or adolescent and a therapist, and is usually used in conjunction with other treatment modalities. Therapeutic interventions are geared to the child's age and developmental progress. The therapist and the child determine what will be shared with caregivers. Older children may deny access of records to caregivers, and caregivers are not in the sessions for individual therapy. Family therapy focuses on relationships and communication patterns of the family members. The goal is to change family interactions and improve family communications to help the family and individuals achieve autonomy, independence, and self-effectiveness. Group therapy involves a group of children or adolescents with a focus on interpersonal relationships. Feedback and support come from the group members, not just from the therapist. This form of therapy is especially good with school-age children and adolescents due to the importance of the peer group with those in developmental stages. The focus of play therapy is to help the child reveal emotions, feelings, and problems. Toys, dolls, blocks, cars, and other objects are used in this type of therapy. Art therapy is used to uses drawings and other art objects to help the therapist gain information about the child, their behaviors, concerns, and problems. Attention deficit hyperactivity disorder, or ADHD, is characterized by inattention, hyperactivity, and impulsivity. The basic impairment is a deficit with inhibiting behavior that interferes with the process of learning self-regulating behaviors. This results in school difficulties, academic underachievement, low self-esteem, and difficulties with family and social relationships. There are 3 subtypes: inattentive only. These are not overactive. Hyperactive or impulsive. These can pay attention but are overactive. And number 3, combined inattentive, hyperactive, and impulsive, which is the most common type. The cause is unknown, and boys are affected more frequently than girls. Factors have been suggested to contribute to ADHD are genetic, neurophysiological, dietary, and even environmental. Clinical manifestations: the disorder is characterized by 3 major behaviors. Number 1, inattention. Number 2, impulsiveness. And 3, hyperactivity. And the manifestations depend on the subtype. Inattention is the inability to sustain concentration for an appropriate period of time and to disregard attending to the external stimuli. Hyperactive children tend to fidget or squirm, are disruptive in the classroom, and interfere with the teaching activities of other students. Impulsive children act before they think, and they are impatient. Assessment. You need to be aware that the term hyperactivity is often used to describe an active child. Have the parent give an exact description of what the child is unable to do relative to tasks. Assess for activity that is not only excessive but disorganized. They may see variability in the behavior from moment to moment. A high level of impulsiveness can cause children to make statements without thinking, to touch an object that they've just been told not to touch, or to speak or act before thinking. But children do that anyhow. There has to be more involved in the diagnosis than just a child not touching something that you've asked him not to touch. Children with ADHD may have difficulty with concepts such as right and left, before and after, yesterday and tomorrow, which is sequencing. They may see difficulty using conjunctions properly. Difficulty with arithmetic and spelling is common. Graphesthesia, which is the ability to recognize a shape that's been traced on the skin. Stereogenesis, ability to recognize an object by touch, may be impaired or absent as well. The diagnosis is use of the DSM-IVTR, which has specific behaviors and criteria for a diagnosis. This is explained more in your book, and you might want to take a look at it. Behaviors must be present before the age of 7 and must have occurred in 2 or more settings, persisted for 6 months or more, and have adversely affected functioning. Therapeutic management is pharmacotherapy, behavior management, educational interventions, and family education. Pharmacologically, a stimulant medication such as Ritalin, Dexedrine, and Adderall are consistently improve the symptoms of ADHD in most children. Common side effects include anorexia, weight loss, insomnia, abdominal pain, headache, tachycardia, and hypertension. If the side effects are not tolerable, other meds may be used. Some other medications may be antihypertensives, such as Catapres or Tenex, used to treat aggression, or antidepressants, such as Wellbutrin or Strattera if they're over 6 years old. Behavioral management includes assisting the child to follow rules, complete tasks, and improve self-control. Positive feedback for appropriate behavior is a component. Educational interventions. A stable environment is desired and is crucial for children with ADHD. Since ADHD is a developmental disability, these children are by law mainstreamed into the classroom. Only when disruptive behavior is severe are these children placed in special classes. Distractions should be minimized, and children need to be reminded to keep on task with chores. Family education, as you can imagine, raising an ADHD child is a challenge. A responsive listening person is crucial. Frequent health care visits may be needed. These parents may need reminders that the child does not act this way on purpose. Since these children have problems with sequencing, suggest parents help them by asking questions such as why, where, and who to help prompt to get to the point of the story. Mood disorders, also called depressive disorders, are common among children and adolescents, but often are unrecognized. There are 2 types of mood disorders: bipolar, depressive. Similarly, there are 2 subtypes of depressive: major depressive disorder, MDD, and dysthymic disorder, or DD. Bipolar disorder is characterized by episodes of depression alternating with episodes of mania. MDD is a single episode or recurrent episodes of depression, where DD is a chronic mood disturbance. There are theories of etiology, but the exact cause is unknown. Children with at least one depressed parent are more than 3 times as likely to have an episode of MDD than those without a depressed parent. Psychological factors or psychosocial factors include family dysfunction, personality dynamics, and exposure to negative life events. Clinical manifestations. A child is considered to have MDD when symptoms such as depressed or irritable mood, loss of interest or pleasure, changes in eating habits, weight loss or gain, psychomotor agitation or retardation, feelings of worthlessness or inappropriateness, guilt, problems thinking or concentrating, fatigue, insomnia or hypersomnia, and recurrent thoughts of death or suicide. The depressed mood and symptoms must last consistently for about 2 weeks. DD is defined as a child having a persistent, long-term depressed mood that is less intense but more chronic than MDD. A comprehensive evaluation is essential. Better assessment to get a history from both the child and the parents. The treatment is usually psychotherapy and psychotropic medications. Counseling to discuss problems is necessary. Cognitive behavior therapy is often used and is a behavioral modification technique using stimulus and response to alter inappropriate behavior. Individual, group, or play therapy may be used. Additionally, antidepressants may be prescribed. Research has shown that SSRIs such as Prozac, Zoloft, and Paxil are both safe and effective in children and adolescents. This is not true of the tricyclic antidepressants. Nursing implications, a major focus is on the education of the child and family about the disorder and the treatment of medications and potential side effects. Suicide is the intentional or purposeful taking of one's own life. Suicide may be completed, attempted, or it may just be an ideation, which is thoughts of killing oneself. Completed suicide rarely occurs in children, but the incidence of suicide reaches a peak in the mid-adolescent years. Children and adolescents at higher risk for suicide typically have a history of depression, have previous suicide attempts, a family history of psychiatric disorders, family disruption, abuse, relationship problems or breakup, and gender ID issues. Your book talks about suicide warning signs. You always want to take it seriously when somebody says that they have thoughts of killing themselves, and you always want to ask them if they have a plan. Therapeutic management, those at highest risk are those with not just ideations, but a thought-out plan. Use of a firearm implies a high degree of lethality. Evaluation by a mental health professional ASAP is in priority. Hospitalization is the safest means of treatment due to the safe environment. Those not at high risk should be referred to the mental health for evaluation and possible long-term therapy. Nursing implications include assessment, including a thorough health and family history, specifically asking about suicide or suicidal ideations. If the answer is yes, seek details about the plan. Management focus on safety of the child and family, keeping the child safe and in the least restrictive environment. Primary interventions are activities that provide support, information, and education. Secondary interventions involve the treatment of the actual suicidal crisis, such as establishing a rapport, incorporating more effective coping methods, and reaffirming hope. Tertiary intervention includes ongoing care after a suicide attempt, or care for family and friends after a suicide. Anxiety disorders. Anxiety is a sense of apprehension or uneasiness caused by uncertain, non-specific danger or threat. Anxiety is unavoidable and can be useful. However, when anxiety becomes overwhelming, it can result in psychosocial changes. Children with anxiety or fear may become overly dependent, avoid problems, or display withdrawal behavior. Anxiety disorders are prevalent among children and adolescents. Separation anxiety is part of a normal phase of development in infants 8 to 12 months, but usually appears by age 2. However, this is considered a disorder when an older child shows excessive anxiety about separation or the possibility of separation. School phobia is a form of separation anxiety where the child has difficulty attending or remaining at school for the entire day. This is associated with a great degree of emotional stress. Generalized anxiety disorder is characterized by excessive worry and anxiety about future events, being on time, or natural disasters. These children are often labeled as worriers and often perfectionists. Obsessive-compulsive disorder is characterized by recurrent, intrusive, unwanted thoughts called obsessions, or compulsive behaviors or rituals. The child is aware that these are unreasonable, and this causes further stress. The cause of anxiety disorders is not known. Theories are that biological and environmental factors play a part, but more research is needed. The child with separation anxiety may present with stomach aches, headaches, nausea, vomiting, low-grade fevers. However, don't discount organic causes here as well. Older children may have palpitations, vertigo, faintness. School phobia or refusal will have a long and short-term effects academically. General symptoms may include restlessness, fatigue, difficulty with concentration, irritability, sleep disturbances, muscle tensions. Children with social phobias may show tremors, sweating, diarrhea, and blushing. OCD children may have intrusive obsessions that are realized as inappropriate, and they're not reality-based. The compulsive behaviors are aimed at reducing distress or preventing a dreaded event. The treatment is to reduce symptoms and relieve distress. That's the goal. To minimize the disability associated with the disorders and to enhance the developmental potential of the child or adolescent. Treatment involves a variety of methods, including education, consulting with school personnel, cognitive behavioral interventions, individual and family therapy, and also pharmacological therapy. Psychotropic drugs should be used only concurrently with other types of therapy. Tricyclics and SSRIs are used, which are antidepressants. Short-term anti-anxiety drugs such as benzodiazepines might be used. Post-traumatic stress, PTSD, is an anxiety characterized by a group of symptoms and reactions that follows an extreme or life-threatening traumatic event. This event can be a single short-term event or long-term. Causative events are usually characterized or categorized as natural disasters, accidental disasters, intentional human-made disasters. Clinical manifestations, they relive the trauma over and over again, and they avoid any stimulus associated with the event, and the numbing of a general responsiveness and increased states of arousal. They may have obsessive thoughts about the event, dreams related to it. Avoidance may include physical avoidance of situations that may resemble the event, efforts to avoid anything associated with the event, decreased interest in the outside world and normal activities. The arousal symptoms include hypervigilance, sleep difficulties, exaggerated responses, irritable, angry outbursts. Symptoms must be present for more than 1 month and cause impairment. The cornerstone of treatment is the education of the child and family. Components are direct exploration of the trauma, stress management, explorations and corrections of inaccurate thoughts and attributions of the event, and this must include caregivers as well. Nursing role is to establish a trusting rapport, offer reassurance of safety and security, explain that symptoms are not uncommon following such a trauma. A nurse can also explore and teach better coping strategies with the patient. Substance abuse is a maladaptive pattern of substance use leading to significant distress or impairment. With children and adolescents, the impairment is usually psychosocial and academic functioning. Substance dependence is characterized by a high degree of involvement with use of a substance, including withdrawal, tolerance, and loss of control over the use. Types that are used and abused by pre-adolescents and adolescents include alcohol, tobacco, marijuana, opiates, cocaine, amphetamines, barbiturates, hallucinogens, and inhalants. Several theories involve genetic factors, family factors, peer influence, individual factors, community or neighborhood factors, and or media factors. The clinical manifestations will vary depending on the type of substance that is used and the age and weight of the child. CNS depressants, such as alcohol, barbiturates, and sedatives, will produce states that range from calmness and drowsiness to delirium and coma. Alcohol decreases inhibitions and may slur speech. Opiates create a feeling of euphoria or analgesia. CNS stimulants, such as amphetamines, create a feeling of well-being or euphoria. Hallucinogens alter perceptions, thoughts, and feelings. Suicide, fatal accidents, and homicides often occur as a result of hallucinations and delusions. Marijuana can cause feelings of unreality, distorted sense of time, and perceptual distortions. Common findings include failure to complete assignments in school, demonstration of poor reasoning ability, decreased school attendance, frequent mood swings, deteriorating physical appearance, recent change in the peer group, expressed negative perception of parents, etc., etc. Treatment varies depending on the substance being used and the willingness of the child and family to cooperate with the treatment, the age of the client, and the availability of treatments. Broad treatment goals include the elimination of the substance abuse and any accompanying undesirable behaviors, and the restoration of the child to a healthy and functional status. Treatment is usually in the least restrictive environment that is safe and effective, but may be inpatient, residential, or even outpatient. The aim of these programs is to increase self-esteem, improve problem-solving ability, realign them with society's values, and increase their self-awareness so they can function normally without the aid of the abusive substance. Medications may be used to help with withdrawal, and there are self-help groups such as AA or NA, Alcoholics Anonymous or Narcotics Anonymous, that are important adjuncts to treatment. Nursing involves the assessment of risk factors, observation of behaviors, taking a complete history and appropriate referrals. Prevention is important education, support, and reinsurance for the patient and family. And remember, patients lie. Eating disorders include anorexia nervosa, bulimia nervosa, and it's common in children and especially adolescents. Anorexia is simply a loss of appetite and can be due to an organic or medical cause. Anorexia nervosa is something else. The mortality rate associated with these eating disorders is the highest of all major psychiatric disorders. Anorexia nervosa is a disorder characterized by voluntary refusal to eat, significant weight loss, an intense fear of becoming overweight, and a pronounced disturbance of body image. It occurs mostly in females 10 to 19, and the exact etiology is unknown, though there are several theories. Clinical manifestations are generally extreme weight loss, refusal to maintain body weight at or above the minimum requirements. They weigh less than 85% of their expected body weight. Intense fear of gaining weight or becoming fat, even though they are underweight. The denial of the seriousness of the weight, and a severely distorted body image. These people look in the mirror, they're very thin, and they still see themselves as fat. Physical symptoms can exhibit as amenorrhea in girls, hypothermia, muscle wasting, cardiac dysrhythmias, hypotension, lanugo formation, cardiomyopathy, dry skin, brittle nails, intolerance to cold, and if untreated, starvation and death may occur. The initial goals of treatment are overall improvement in body weight, normalization of eating patterns, and the restoration of physical health through weight gain. Treatment is usually complex and long-term because the real issue is not food. The real issues are poor self-esteem, a need to be in control, a need for perfection, not food. Other goals include correction of any medical complications such as fluid and electrolyte imbalances, improve in personal, social, and family functioning. Hospitalization is generally limited to a brief, acute visit involving weight restoration and just getting them to eat. However, weight gain should not be too rapid because that can cause a cardiac overload and even death there. Medications have been used, but only SSRIs have proved to be effective. Bulimia nervosa is characterized by episodes of binge eating, which is eating large amounts of food with a lack of control, followed by various compensatory behaviors like self-induced vomiting. This behavior is accompanied by awareness that the eating pattern is abnormal, but the inability to stop. The person then has guilt and remorse and gets rid of it. The typical bulimic client is a female aged 15 to 30 with peak around 18 to 19 years old. Many have periods of normal eating interspersed with binge and purging, or they may move from binging to fasting. This person is unable to express feelings of appropriateness. They have low self-esteem, depression, and substance abuse may be seen. They have intense fear of getting fat and are overly sensitive to weight gain. Binge eating is done in secret and generally stops with abdominal discomfort. The binge purge cycle is recurrent, and the bulimic loses the ability to respond to normal cues for hunger and being satisfied. Vomiting and laxative misuse results in dehydration, abdominal distension, fluid and electrolyte imbalances, esophagitis because of the gastric juices, and esophageal lacerations because of the vomiting. Gastric acid erodes the tooth enamel, resulting in dental caries. And you can have cardiac hypotension, a drop in the blood pressure, along with arrhythmias and even cardiomyopathy, which is an enlargement of the heart. Treatment includes individual, group, and family therapy and pharmacologic interventions. Behavior modification is used to control the binge-purge cycle, and cognitive therapy may be used to change beliefs about their self-esteem, their body image, and in their self-concept. SSRIs are helpful in controlling the binges, and hospitalization may be necessary if physical complications such as fluid and electrolyte imbalance, dehydration, those kinds of things begin to manifest themselves. Failure to thrive is a term to use to describe a child with inadequate growth, usually weight, on standardized charts. There's no clear consensus except the child's weight that's usually below the 3rd to 5th percentile or falls more than 2 major percentile groups. The causes are usually classified as organic, that there is a physical problem, or non-organic, which is psychosocial issues or even mixed factors. Organic problems include GI problems, such as GERD, celiac disease, or pyloric stenosis. Other organic problems may be chronic illnesses, infections, or related increased metabolic conditions. Non-organic causes include poverty, poor social support, family stress, inadequate nutritional information, errors in nutritional preparation, inadequate breast milk, difficulties in the maternal-child bond, or maternal psychopathology that interferes with the ability to take care of the child. Clinical manifestations include growth failure, failure to maintain previous growth, loss of sub-Q fat, reduced muscle mass, developmental delays, apathy, listlessness, flattened occiput from lying in one position because they haven't been moved, infrequent and scanty stools, signs of neglect such as poor hygiene, diaper, dermatitis, poor eye contact, and a flat affect. The goal of treatment is to provide enough calories for the child to catch up. They need about 150% of their required calories daily based on the weight they should be, and a multidisciplinary team is the best approach. Nursing focuses on the observation of the caregiver and child during feeding and when not feeding. Education about appropriate feeding is essential, and the nurse monitors a weight gain, intake and output, and encourages regular health checkups.